Bismillahirrahmanirrahim. The topic is tips for better abdominal ultrasound. We will be discussing some of the important tips. I am Professor Dr. Sayyid Amir Gilani. First thing is some of the common sonographic signs. The first sonographic sign, which is of prime importance, is SEAGULL sign, in which the vessel which is important is celiac trunk, which is arising from aorta. In this scan, you can see this is aorta, and here is the celiac artery, which is giving us branches, splenic artery and hepatic artery. It looks like the wings of seagull, and here is the seagull. On Doppler, it appears like this. Here is aorta, the celiac artery, and then we have got the splenic artery and hepatic artery. So this is called SEAGULL sign, formed by four vessels: aorta, celiac artery, splenic artery and hepatic artery. Then is Comet-tail. Comet-tail occurs in many cases, many pathologies. We commonly see it with the gallbladder also. For instance, here we have a polyp which is in a gallbladder at the anterior wall. So as there is bile inside, the polyp is like a floating structure. So once the sound waves strikes, there will be movement in freely hanging polyp. Due to movement, it will give mixing of color. On grayscale, it gives us an artifact which is called Comet-tail artifact. Very thin lines. It is a short meter type of reverberation artifact. It occurs due to cholesterol crystals deposited in the gallbladder, where the Rokitansky-Aschoff sinus, resulting in bright reflections, and short V-shaped artifacts behind these crystals are formed. So the polyps, especially having formation of the sinuses, having cholesterol crystal deposit on them, will give us this type of artifact. The third sign is called target sign, which is seen in intussusception in the intestines. So we can have multiple alternating hypoequic and hyperequic layers due to the presence of overlapping mucosal and muscular layers of the intussusceptions. There will be the outer surface, the layer receiving bowel segment, and the inner one, which is the inverting segment, is called intussusceptum. The next ultrasonographic commonly seen sign is yin-yang sign. The Doppler ultrasound findings indicate flow occurring because of swirling, which is churning movement of blood within a dilated vessel, usually depicted in aneurysms or pseudoaneurysms. This is the pseudoaneurysm which is near to the vessel, and actual real aneurysm which is within the vessel, arising from the vessel. Next is Mickey Mouse sign. This appearance is abdominal, is seen in the abdomen, and is given by identification of the portal vein, which corresponds to Mickey face. The hepatic artery is here, corresponding to the left ear, and the bile duct corresponding to the right ear. This is portal vein, bile duct, and the hepatic artery. Then is banana peel sign. It is a peeled banana. The banana peel sign is described when a coronal view of aorta and renal arteries is required. So we get aorta and renal arteries originating from aorta. This is that area. So it is the coronal view in this image, in the right flank. It can be reached easily when the patient is in left lateral decubitus. And the appearance resulting in banana peel is given by aorta as the banana and the renal arteries as the skin of each side. Then is Playboy Bunny sign. The Playboy Bunny sign is dilated hepatic vein. These are the dilated hepatic veins with IVC. So these are hepatic veins draining into the IVC. It looks like a bunny head sign. These are the 2 ears and face of the bunny. Stag head or moose head sign. This is seen when the hepatic veins are draining into the IVC, and when we scan the liver transversely, we get this type of head. It is the same area where we saw the previous sign of Playboy Bunny sign. This is the stag head sign, which is also called moose head sign. The face, and then we have the horns. Then is whale tail sign, atelectatic lungs with effusion. So whenever there is effusion, this is effusion, and here is the tail, the two sides like this. Here we have two sides of the tail of the whale. So this is called whale tail sign, seen when there is pleural effusion with atelectatic lungs. Next sign is double barrel sign. It looks like two barrels and is seen when there is a dilated duct, this one. It will appear with the same caliber or even thicker than the portal vein. This is portal vein, but common bile duct is appearing in more in diameter. The most common cause for this appearance is a choledocholelithiasis, which is obstruction due to stone. So whenever there is obstruction of the common bile duct, it will be dilated and it appears like this. The second thing is sonographic findings checklist in adenomyomatosis. In adenomyomatosis, we get three types of thickening. First is the diffuse thickening of walls of the gallbladder. Second is segmental, one of the segment, upper or lower segment is involved. And third is the fundal end is involved. So there will be mural thickening. And second thing is, as there adenomatosis, there will be Comet-tail artifact, which is the most specific sign to adenomatosis. It is an echogenic intramural focal form which emanate V-shaped comet-tail reverberation artifacts, representing a unique acoustic significance of cholesterol crystals within the lumina of Rokitansky-Aschoff syndrome. We have already discussed this Comet-tail artifact. Here is the fundal type, the mucosal folds forming the Rokitansky-Aschoff sinus. This comes the muscular layer which is thickened. So mucosal layer is giving us projection-like appearance. There will be crystal deposition on it, and then with color Doppler we can get mixing of colors, and on grayscale we can get the Comet-tail artifacts. This is a normal gallbladder. Diffuse whole of the wall is having small polyp-like structures, which is diffuse adenomyomatosis. Then is the fundal type and segmental type. The body is having, but the fundus is clear. So in adenomyomatosis is part of the spectrum of degenerative and proliferative changes seen in gallbladder, termed hyperplastic cholecystosis, the other variant being cholesterolosis. Its etiology is unknown, so these will be the sinuses which are formed. In Comet-tail artifact, so the cholesterolosis versus adenomyomatosis, both may have the echogenic foci with Comet-tail artifact at gallbladder wall. The cholesterolosis results from abnormal deposits of cholesterol esters in macrophages within the lamina propria and in mucosal epithelium, whereas the cholesterol accumulation in adenomyomatosis is intraluminal within the Rokitansky-Aschoff sinuses. So these are deposits, whereas these are accumulation of cholesterol at sinuses. So first the sinuses form, then crystals are deposited. Whereas in cholestylosis, only the deposit is formed. We will not find the sinus behind the cholesterol crystals. This is a diffuse type, longitudinal and axial view thickening, and you can see the diffuse thickening of the gallbladder wall with Comet-tail artifact. Focal mass, in this scan you can see the focal mass. This is magnified view. It is localized at gallbladder fundus with echogenic foci creating Comet-tail artifact. This is the most common localized type. Then we have annular type of gallbladder mid portion with Comet-tail artifacts. These are multiple Comet-tail artifacts. This is in the middle. The third part of our discussion is normal renal variants. We will discuss the four very common renal variants, which are the dormitory hump, prominent column of BERTIN, junctional parenchymal defect, and persistent fetal lobulation. The first is dormitory hump. This is a hump, a projection mostly at the center of the kidney. It looks like this hump of the camel. Here it is on sonogram. This is a focal contour bulge of lateral interpolar aspect of the left kidney. The dormitory hump is caused by molding of the normal renal parenchyma. This is the normal renal parenchyma which is molded by the adjacent spleen. Here is the spleen. And it should be recognized as a pseudomass, obviating the need for additional unnecessary testing. So if we know that it is a normal variant, a normal structure, a bulge which is normally seen, most commonly seen in females, and it is not a mass, it is not a pathology, then we will not mix it up and we can avoid unnecessary things. Then is another variant which is called prominent column of BERTIN. It is also a normal variant of the kidney formed of hypertrophied cortical tissues located between the pyramids. These are the pyramids that project into the kidney or renal sinus, resulting in splaying of the sinus. Column of BERTIN is usually located in the middle third of the kidney, more commonly in the left kidney as compared to the right. So this is a bulging inside. Then is the junctional parenchymal defect. Sometimes we get a hyperactive wedge-shaped structure inside the kidney in the cortex. It is junctional parenchymal defect which produces this wedge-shaped hyperaquic defect in the anterior aspect of the kidney near the junction of the upper and middle third because of incomplete embryologic fusion of the upper and lower poles. Persistent fetal lobulations. So the lobules which fuse to form the fetal kidney, Their outline remains persistent and is visible. So these are the persistent renal lobulation, which is a normal variant seen occasionally in adult kidney. It occurs when there is incomplete fusion of the developing and renal lobules. Embryologically, the kidney originates as distinct lobules that fuses as they develop and grow. So sometimes that outline remains there and kidney keeps on growing. This is normal. Then we come to the polycystic kidney disease. The polycystic kidney disease on ultrasound we will have some specific features. Bilaterally involved kidneys involved in the liver is involved in up to 50% of the cases. The pancreas can also be involved in 5% of the cases. The most common hereditary renal cyst disease is this polycystic kidney. Defect in two genes, PKD1 and PKD2. Signs and symptoms are hypertension, palpable mass, abdominal pain, hematuria, renal infection. We can differentiate it from acquired cystic disease. This is polycystic kidney and here is the acquired cystic disease. This one is hereditary from the inheritance seen in younger patients, whereas the acquired, it is not from inheritance. It is seen in older patients. In polycystic kidneys, we have previously healthy patient. Here we have history of long-term dialysis. In polycystic kidneys, enlarged kidneys, whereas in acquired cystic disease, it will be echogenic shrunken kidney. There will be no increased risk of renal neoplasm, whereas in acquired cystic disease, there is risk of solid renal neoplasm. Macroscopic and ultrasound comparison, we can see the nephromegaly, enlarged kidneys which are above 13 centimeters in length. Kidney parenchyma is commonly replaced by cysts. There are multiple variably sized cortical and medullary based cysts, and simple cysts more common. Low level echoes also appear. So on ultrasound they will appear like this. This is polycystic disease. We can use other modalities like CT. Here you can see the multiple bilateral cysts as a rule of thumb for finding. There will be low level echoes. There are low level echoes and there will be proteogeneous or hemorrhagic contents inside which make them low level echoes appear hyperdense at CT. We can get echogenic foci with posterior reverberation, this one, due to crystal deposition. This is the longitudinal view and transverse view of the polycystic disease in liver. Liver is involved in up to 40% to 50% of the cases of autosomal dominant polycystic disease. Despite extensive replacement by cysts, liver function remains normal in most patients unless there is associated hepatic fibrosis. Symptoms may arise from the mass effect of the numerous cysts. As they unite, they appear like a mass or may result from cyst hemorrhage. Then the fifth point of discussion is portal vein Doppler. If you look at this diagram, we have this splenic vein, superior mesenteric vein, and portal vein giving its branches in the liver. It is formed by the confluence of the superior mesenteric and splenic. The flow in the portal vein is directed towards the liver and is therefore called enterograde or hepatopetal flow. Scanning techniques. We can scan for the subcostal while the patient is lying supine, or we can scan intercostal. The normal diameter of the portal vein when measured in this direction, the width is up to 13 millimeter, and some of the authors they say it is the upper limit. And the flow direction of the waveform. The flow in portal vein is antegrade hepatopetal, which corresponds to a waveform above the baseline aspect of the Doppler ultrasound. It is phasic flow with gently undulation, and the velocity is 15 to 40 centimeters per second. Spectral parameters of gain and scale. Gain should be adjusted to outline the contour of the depicted waveform, and PRF should be set it to a range of 1500 to 3000 Hz in order to depict appropriated velocities with an improved appearance of the spectral waveform, providing more visible quantitative and qualitative data. This is the velocity, which is here it is about 20. On color Doppler, note that an intercostal approach, the antegrade portal flow, is more towards the transducer. The color bar depicts the flow in red. Here it is. And here, note that the subcostal approach, the antegrade portal flow is moving in opposite direction to the transducer. The color bar depicts blue. So keep velocity scale between 15 to 30 centimeters per second, and this is how it appears. The flow velocity in portal vein vessel is relatively low, 15 to 40 centimeters per second. If the measured flow velocity falls outside the selected scale, a lasing of the currently active scanning mode will occur. So there will be mixing of color. This is angle correction. The ideal angle is 45 to 60 degrees. Then the sixth thing which is important is ultrasound for acute appendicitis. For acute appendicitis, we have primary and secondary signs. The primary signs includes maximum outer diameter of more than 6 millimeters, incompressibility of the appendix, presence of appendicolith, hypervascularity of color Doppler. The secondary signs include the hyperechoic periappendicular tissues. Periappendicular fluid is seen, complex fluid collections, and mesenteric lymphadenopathy is noticeable. Here are the mesenteric lymph nodes which are enlarged. You can see the mesenteric lymph nodes on grayscale and on color Doppler. These are the lymph nodes, and here we have a cut section of the appendix. Goals for ultrasound examination of appendicitis must be exclusion of an alternative abdominal disease, confirmation of typical appendicitis, ruling out of acute appendicitis by providing a normal appendix over its entire length. This is cut section 1.1 centimeter, and here it is 1.12 centimeter cut section measuring the hyperechoic periappendicular tissues. These are the hyperechoic periappendicular tissues, and the outer diameter is above 6 mm. It is about 11 mm. Longitudinal and transverse view. The primary sign involved direct visualization of the appendix. Secondary sign related to finding adjacent to the. This is appendiculate within the appendix, swollen appendix, and we can get some fluid collection outside the appendix also. With this, we finish this talk. Thank you very much for listening.